Buenas tardes, bienvenidos de vuelta al trabajo de la tarde. Good afternoon, pleasure to have you back. Let's give it a couple of seconds for people to come, find their place. Okay, now that I think that kind of have your attention, let me welcome to this very interesting section. In this session, we're going to have the pleasure of Dr. Javier de la Cruz showing us the results of a bibliometric analysis, and an analysis that goes far beyond that simple approach to get an idea of how scientific information regarding KMC is being represented in the scientific literature, how is it penetrating, and what are the current status and probably the future research opportunities, publication opportunities, gaps that needed to be filled, and to understand how to focus our attention in the really key aspects in order to push the appropriate translation of knowledge into action. Dr. Javier de la Cruz is an MD and a clinical epidemiologist. We share the same secondary discipline, it's an honor, from Hospital 12 de Octubre. He is the coordinator of clinical research at the Hospital Research Institute. And one of his main tasks now is to promote and facilitate the participation of the hospital research groups in international research, innovation, and technological projects. He spent a couple of years at the Joint Research Center in the European Commission working on healthcare information systems, and we're going to pick his brain for his wisdom in that respect. And in pediatric research, he has worked on the epidemiology of cerebral palsy and has coordinated the surveillance of cerebral palsy registry in Europe. And he's been a very good friend and a close collaborator with the neonatology department at Hospital 12 de Octubre. Thank you very much, and welcome, Dr. Javier. Please.
Thank you, Professor Ruiz, and thanks to the steering committee for inviting me to present and to talk on this topic. Probably, if you ask me to talk on this, is because you wanted an external view, to gain an external view, and this is definitely what I can provide, because, well, I'm not a practitioner and I don't perform specifically research on KMC. So I hope the topics I will cover will raise some points for discussion, and I hope Professor Ruiz, you will help me to make sense of all this and to put that in context. So the points I would like to touch is first very quantitative approach on the literature. Then I'd like to spend some time on issues of the medical literature and on the evidence of KMC and the problems that it may raise or not. And finally, I would like to stress, to underline two topics that have been mentioned by different presenters in this meeting that I think will be very important in the future. So we will start with, to set the scene, with bibliometric analysis. This is very quantitative. It's just, well, now there are some methods and tools to process all the information that there is in a bibliographic database. And very recently, there was a paper by a Spanish group that took some time trying to describe the publications on KMC in premature infants in the NICU. So it's not an overall view of the publications in KMC. It's quite specific, but it will provide some indicators and some diagrams. we'll go through two bibliometric analyses, and this is the first one. So they use Scopus database. They identified 200 papers that written by 160 authors from more than 40 countries in 110 journals. So it's quite a big diversity. And what were the results? Well, on the bottom right, in the blue line, we see that there is an increase, a step increase from 2010, 2011, up to now on the publications on KMC. So this is the first results. There is clearly a lot of activity in the last 10 years. There are a lot of citations as well in this graph in red with two peaks around 2004-05 and around 2012-13. Okay. On the upper right, we see that mainly these papers are classified in medicine and nursing. We will see more details later on. But almost all papers are on medicine and nursing. And on the left, we see a diagram graph based on citations. So the analysis is on the number of citations, and the closest the authors are based on citations. And we can see here with more detail that there are clearly different networks. Probably you can interpret much better than me who are these authors and why they are so close and why the points are brighter and bigger, particularly in the center. And I think there is some interesting information here about, as far as what I can understand, about the type of relations and networks and the highly cited authors. So this is one type of results of the bibliometric studies, but we are going to go to a second bibliometric analysis, which I think is more interesting. It has a wider picture. It's about prematurity. And so we will try to look at KMC within the prematurity field. They use another database for this analysis, the Web of Science. They included articles and reviews. And so again, as previously, on the bottom left, we see the first result. So the publications increase in all fields, but on the right, we can see that clearly it increased more in the field of prematurity, in red, than in the general, in the rest of the publications in blue. So publications on prematurity are growing or increasing at a faster pace than the general literature. On the left, we see, or the right, we see that there are 5 big areas of research. The most important one in prematurity is obstetrics, then pediatrics, but also public health. And so it's interesting that it touches different areas of research, also reproductive biology and general medicine. So this is the first result. Second result, it's quite interesting. So it's a visualization based on the analysis of terms that are identified in the titles and in the abstracts of publications on prematurity. They went through 50,000 publications on prematurity in the last 20 years, and clearly the colors indicate different clusters. The clusters could be described by their center of interest. So in yellow, we can see causes and prevention of prematurity, mainly. In red, upper left, it's more obstetric conditions. In blue, on the right, it's more basic research. And then on the bottom left, we see in green neonatal outcomes, and in purple midterm, long-term outcomes. In orange, it's more related with ophthalmology. And so this makes sense. So this map is based on terms that occur frequently together. So it's a distance map. Some terms make sense, others not so much. But so we are going to look at a bit closer, and it's yeah, can't see what we are looking for. So we are going to zoom in a bit on the left. So we are like in the west coast of the right map, and closer to where neonatal outcomes, longer term outcomes, and a bit obstetrics meet. And so we see concepts that are quite familiar. We still don't see what we are looking for. So we zoom in a bit more. And this is what we see. And now, do I have a pointer? Yes. So here we see KMC, kangaroo mother care, breastfeeding here, skin contact, oops, sorry. Skin contact down here. So KMC is on the map. It's not. It doesn't have a big presence, but it's on the map, and there are a lot of limitations to the type of analysis. But I think it's interesting to see where it is. By the way, the most interesting thing is to see over time what has been the presence of KMC. So we are going to see exactly the same figure, but with different color pattern. In yellow, we will see the most recent publications, yellow, green, and in blue, the less recent, in the last 20 years. And this is what we see. We see that kangaroo mother care and KMC clearly is quite a recent phenomenon, and it's increasing. If we go back to the first picture on the left, we see that it's not the same for all the concepts that we can see here. We see a lot of blue or dark green, but definitely on the west coast where KMC is, it's quite yellow. So one of the things we can conclude, so it's that there is clearly a higher growth in the number of publications in the prematurity field than overall. That we can find prematurity publications over different research areas. We identified author networks. And in the visualizations, we could see that KMC is on the map, although with a limited presence, but it's a dynamic and growing field of research. And there is clearly a shift, we can go back, from basic research to neonatal characteristics and outcomes, so from blue to yellow. So this is quite a favorable outlook. Obviously, there is a lot of limitations to this study. The first thing is, what are we talking about when we talk about a KMC publication in this database? We really are not very sure, because KMC can be an eligibility criteria, so we are studying only newborns that are receiving KMC, or it can be a study, comparative study, where KMC is the main intervention or a determinant, but KMC can also be an outcome in a study. So really, if we want to make sense of this, we should really close the question, the research question, and do much more specific studies. So this is, we tried to do a very quick dip in a web of, this was in Medline. We used a mesh term for KMC, so it's more specific, it's a narrow search, so probably these publications are about KMC. And the first finding we can underline is that 18%, so almost 20% of publications in this selection of publication are clinical trials. At least they are labeled as clinical trials. This is quite a high proportion. The second result is that if we use the impact factor, we see on the right that in the first two quartiles, so half of the publications in the KMC field are in the first two quartiles. So it's quite a favorable result. I think it's not a literature which is publishing journals that are not in GCR or that are in the lowest quartile. If we want to compare with, to have the reference of another field of research, prematurity, with a much higher number of publications, to 23,000, we see that the proportion of clinical trials is much lower, 9%. And then in a subsample, we just tried to look at the distribution of the publications on prematurity by impact factor quartile. And we see that in prematurity, there is at least a 50% increase in the first quartile. So publications in prematurity, clearly, there are more publications of prematurity in the first quartile of all in this field. This is without looking at specific categories. It's all publications together. So two interesting results here. And then we are going to look at in what journals are published the KMC papers. So we are looking in Web of Science, in the pediatrics category, and we are looking at the first quartile. This is the 32 journals with the highest impact factor. There are 260 publications in 90 journals. And so you are familiar with this list of journals. There is one journal with a lot of publications, Pediatrica, and others that have some publications. It's not very easy to interpret this data because Pediatrics, who has a significant number, 43, but if you think about on the denominator, the number of publications in pediatrics is huge. So it's really several thousand every year. So maybe 43 out of a lot of thousands along 10 years, maybe it's not very much. There are journals in the first quartile where there are no KMC publications. And here we see the whole list. So publications in a lot of journals, but not in some of journals. This may be a problem. The same for the second quartile. There are a lot of publications in 23 journals, but not in 10. And so I think it's quite favorable result, but it seems that there is maybe a problem. So we see a high proportion of clinical trials, high proportion of publications in the first quartiles, and presence in a lot of journals. Problems, we have no information on the submissions, and this probably would be much more informative. And maybe there is an issue with some key journals where there are or no or very few publications. So these were the results. Now I'm going to touch 4 points briefly. One is okay, KMC has good results, but it's not winning the race of the publication game. But maybe it's not a big issue, because we know that there are very serious problems in the publication world, driven with external factors and internal factors. External factors, career advancement, etc., which is a bit perverse in the publication game, but also because journals want a type of publications, and maybe it's not what KMC is providing. So just as an example, on the bottom right publication, I mentioned that the most cited publications in pediatrics were not published in high impact factor journals, were not clinical trials or systematic reviews. So there is life outside the most highly ranked publications types and publication journals. Second topic I would like to touch. So maybe it's not a problem to be there. So you have analyzed barriers and enablers, and very rarely the availability or the quality of the evidence on KMC is mentioned as a barrier, at least in these studies. It seems that the KMC community has produced enough evidence to develop practice guidelines, and maybe there is no big issue with the publications. There is frequently reported a lack of guidance on KMC implementation. And the two last points I'd like to touch, and I'd like to emphasize that I had selected this beforehand, but I was very pleased to hear several works presented in this Congress that mention this point. So the first one is, what data, what publications will we need in the future or are coming? So there is this interesting paper about the medicine, the future of health, where the wise scientists speak about a connected and data-driven world with patient value, patient feedback, and patient empowerment shape a continually learning system. Well, it seems that we should be there as well. So what is changing really? Well, the main thing that is changing in the data world is that up to now, the data were only produced by researchers, by scientists. And now a lot of other data are being available. The electronic health record registers, patients' hubs. We know that this is coming, this is already here, and it may not be very important in the KMC world up to now, but it will be absolutely everywhere very, very soon. So we are not the only producers of data as researchers. First of all, clinicians will start to produce data because the electronic health record will be reused very, very soon. It's not a technological problem. It's not a problem of models or data architecture. It's just that we need to implement that. And we will have a lot of data from patients. So we need really to harness the full potential of health data. And what do we need? We need to develop a common language and to standardize criteria, classifications, because this will allow to join data, to do pooled analysis, and this will be a big change. And this is already there in a lot of fields, and this will happen. A lot of work, fantastic work, has been done on standardization of information in KMC. But it's mainly about public health indicators. It's mainly about coverage. It's not about individual data. We have listened in this conference that different groups are proposing to collect on a population base a lot of data, but this should be really a high priority, to have granular data on individual cases and not only indicators of coverage. And this will never happen by itself. You need to really to drive and to do a specific work. I'm sorry, I think I'm running out of time. Last point I wanted to touch. So it's healthcare delivery is changing. There are limited resources. So everywhere there are limited resources, more or less, but limited resources. We know that there is a lot of waste, and so new models will be developed. In Europe, and in the States, clearly, there are different models developed about value-based healthcare. There are fantastic experiences going on, and the key thing I wanted to underline is the players are identified. It's the patients, it's the payers, and the healthcare providers. And the new models will have to be built on this type of relation between these three. And on the data side, what we need is to really document what are the values of the patients. This means to understand much more what are the outcomes and preference, patient-reported outcomes and preference. A lot of work has been going on this. Particularly, there is this organization, ICOM, which has developed a lot of data sets, but one on pregnancy and childbirth, another one on preterm and newborn health. And these are excellent examples. The idea is to use these data sets everywhere to be able to benchmark and to really negotiate and develop new standards of care with the patient reported outcomes and preference as a key driver. So to synthesize, KMC publications are on the map in the prematurial field across diverse research areas, settings, and this is really, really remarkable. Quite high scientific excellence, and most important, impact. But clearly, I think there is a problem which is not completely addressed. There is something stopping the implementation, and what we have seen in that there are some journals where KMC is not succeeding in publication. It's probably related. There is something that we don't identify, even in the studies on barriers and enablers. For the future, I think it will be very important to standardize individual level data and to document patient-reported outcomes and preference and resources as well to develop new standards of care, because the standards of care, it's not something related to recommendations only. It's something that where the recommendations are important, but we have to be guided by patient preferences and by available resources. I just would like to thank the neonatology team who has taught me a lot in these years, and thanks to that I was able to read all these papers. Thank you.
Thank you very much, Dr. de la Cruz, for this excellent and provocative presentation. We have close to 15 minutes to take advantage of your presence here to question, to propose, to discuss, to brainstorm a little bit. So I invite the audience to please participate. It's not necessarily questions, but dialogues. And not everybody at the same time, please. I know it's kind of out of our usual zone of comfort, but it's interesting. And I would refrain from starting the questions because I prefer that you go on.
I have a question. So, Juan Gabriel, I'm pretty sure you know about projects that are really working on this standardization of individual data, patient data, in the KMC world, and I think it's a very important topic, because more or less KMC is like is it done, yes or no? And we have heard that it's much more complicated. I mean, all patients are different. I don't know if even in the clinical trials there is enough granular information to do stratified analyses. I think this is often lacking, but I don't know if missing. I don't know if it's...
Well, I can try to answer that from my specific perspective, but the perspective of the whole community that is here is much more wider. But yeah, our focus in research has been very, very on biological targets and morbidity-centered targets, and lately a little bit more on patient and family-centered outcomes. There is also a lot of social sciences research that is in parallel, but as you can see, for instance, in those areas of the literature, they were not reflected in the, and probably are reaching a different audience when there is anthropological perspectives or qualitative studies of parents. Usual healthcare gears say, yeah, interesting, but I don't have time. Let's go for FO2 and for mortality rate and for medication. So yes, as we are been trying to look into a little bit on cost effectiveness, we were faced with the challenge of trying to figure out one decent measure of quality of life of the mother-infant diet during the first years of life. And we went to the literature for guidance, and we became empty. There are some standard quality measures for infants, toddlers, etc., that makes no sense in this scenario. So we kind of figure out a series of qualities of life standards, but they became very, very biased towards neurodevelopmental indicators, readmissions, etc. So we were not able to navigate outside that field, and I guess this is a very important area in which we need to progress, to try to understand patient values and to try to assign a numeric value. Be brave to put a price in life, because resources are always limited, and the only way of negotiating is showing, yes, with this money we're buying this value, and the value is multidimensional, but we need to translate it into some quantitative approach to be able to guide decision making. It's not to do decision making according to, but to guide, to inform. But I will invite the rest of the audience to contribute on that. But before that, I know that there was a question here, please.
Hear me? Yeah. My name is Silke Mader from the European Foundation for the Care of Newborn Infants. First of all, thank you for this critical and really important presentation. So we as patients or parent organizations, we find it extremely important that we have data and arguments for kangaroo mother care, for breastfeeding. And what we are often struggling also is that many of the publications are then even not open access. So we try really, we had just 2 years ago, we had a publication about if parents would be a drug because of kangaroo mother care. But this was not an open access, so we could even not spread the message because it was closed. It was only when you buy the article. That is one thing what really is important, that you think about publish in open access, that we have access to this information. Then the second is, I'm thankful that you have mentioned the iChome project, because this was funded by us from EFCNI. And what was really interesting to learn is that what you said, what is meaningful for parents. And our parent group from all over the world was thinking about what is really meaningful for us, because the doctor said, yeah, BPD is an outcome, or surviving is an outcome. But for us, it's important that this child can maybe live independent, that this child has a happy life, that also we can cope with the situation, that this child find friends. So totally different things what you guys think is important as an outcome measurement, and and it's really rare. It was the first time that I saw it in a presentation, that this is really important, that we measure it and that we also measure what is important for us, because we can live better when we know our child is happy, not only survive, but that we really can cope the rest of our life on it. And so this is really important that you present this on such a conference, that we understand, because we need this to implement it. We need this to argue against all the people who we have not convinced yet. And so this is why it is important to have such presentations like yours on conferences like this, because we all are friends of family center care and kangaroo mother care. But this we need on the other conferences to convince the people. And thank you so much for inviting you and giving this presentation. Thank you.
If there are not other specific questions, I would like to invite the audience to offer answers to Dr. Javier's question. Any ideas of how to incorporate actual preferences and values and granular data, clinically, not clinically, medically, but in the provision of healthcare and interaction between the healthcare provider and the family and the infant or the child? What data should we be able to collect to inform what is going on? Dr. Adriano, please.
Yes. Some of you may remember the first international meeting we had in Trieste. And we were able to organize that meeting because with the funds that we had for our randomized control trial, we were so austere in running the trial that we saved about 10,000, what amounts to about 10,000 euros now. And with that money, we organized the first conference. You may remember that. Now, in that trial, if you look very carefully at the results, we had three components. The first and the most important one was the randomization and the effect on breastfeeding, outcomes, weight, and so on. Then there was a second component, which was acceptability of the method by staff and mothers or families, let's say. And my wife, who is here, was in charge of that part, and she got her PhD based exactly on that. And if you read very carefully the paper, there is something on that. And then we had a third component that should be run by an economist, and that was the cost compared to conventional care in the same hospitals where we ran the trial. So we were already very aware of the importance of doing the three things together. Why did we not go ahead? Well, because it's if you want to do it in a very serious way, you need money first, that we didn't have, and second, you need special skills. I mean, we did the trial, I think, in a very good way, because we had very good neonatologists and neonatal nurses and researchers and so on, but we didn't have specialists in social investigation or qualitative investigation, and even less people who are strong in economic and financial and costing and all these things. So we should have, in fact, expanded our unit to include, staff with those skills in order to be able to pursue that avenue. But otherwise, for many units that are many clinical units around the world, it's very difficult to do that. And we have to sort of rethink the way we are building a unit for that.
Dr. Sherpak, please. Dr. Natalie.
Yes, I really think that it's very important to diffuse results. They can be a clinical trial, but descriptive results too. It's very important for all the community, for example, working or people interested in kangaroo. But for example, actually the feeling is that all the journal who can have a large diffusion are asking for to pay for open access. And they are asking to pay for open access. It's really expensive. So it's more difficult. If you are publishing and you don't have which university agree to pay that, it's impossible. So in the philosophy, it's because I want to be open access, but in the same time, it's a frustration, no?
I don't think so. I think it's new, and it's expensive. But the problem is that we didn't plan it initially. So we planned that the research will cost 50,000, 20,000. We didn't plan that we needed 2,000 more for the main paper to be open access. It's something new. We didn't plan for it. We cannot change that. It has a cost. And so I think it's more that we need to plan from the start when we apply in a grant that we need some money for data management and for publication costs. It's just it has to be planned from the first. It is expensive, and it can be even, sometimes you don't publish in some journals, but if it's the main result of the paper, it's a very tiny proportion of the total cost that provides open access, so parents can read it, people that have no access, privileged access to the databases. So I understand it's a cost, but it's just a problem of planning the expenses.
No? Yeah. I just can agree that we need open access, Natalie, because when we have it really open access, then we can go to politicians, we can fight in the public, we can spread the message and go to us. We have parent organizations in the meanwhile all over the world, and we are supporting you in paying because we plan, as you said, we plan all our research projects, everything what we do, even a commentary everywhere, the open access, and it's between 2,500 and 5,000 euros, and Nature, if we would reach this goal, then of course more, but we are happy to collect the money for having a publication in Nature, in Lancet or whatever, because this is impactful for what we are doing, and this is why we always, when we had yesterday evening a discussion to publish something in ACTA, and I said, why don't think on Lancet? When we fail, maybe then the next one, because this is why we had eClinical, because we have BMJ and Lancet with the zero separation and COVID study, because we asked immediately at the Lancet, what can we do? How must the quality be? And then we had discussed with them what we can do and how big our goal should be, and we planned from the very beginning. We cut another project just to be able to have open access for all our publication we are doing. And that's also for the iChome. We cut another project because we had to pay it ourselves, and we cut it because of having iChome project. And so this is something where you can work with us. The ones who were in the workshop on the first day and had listened to me, what we can do, we can help in making all these publications who are really meaningful for us all together, making open access. And this makes an impact. The higher the journal, the better we have, the more chance we have to implement it. And this is what I understood when I started my life in working in this community. Mrs. Mother, show me the evidence. And when you show the evidence, and we show it as high as possible in the biggest journal we can have, then we show these guys who are against us the evidence, and then we can argue much better to implement it. That is what we have to understand. Emotion is one thing, facts is the other.
Well, we're running out of time, but I'm going to bite a couple of minutes because we were forced to start late, so fair is fair. I would like then to summarize some of the key messages here that probably we will need to reflect a little bit on them. And it's very welcome, this insider but outsider view that you brought to us that brings our attention out of our zone of comfort, as I was saying. One key thing that I take from what you're saying is that we're bumping into barriers, and apparently one barrier doesn't seem to be that there is no published evidence, but implementation methods and feasibility is what is lacking, and apparently randomized controlled trials are not good to answer that. We need another type of research and publications. And probably we are not targeting the right audience. Who reads New England Journal of Medicine? Physicians. And who are the stakeholders? Physicians, nurses, mothers, payers, the community, everywhere. So we're having a very, very focused audience that is appropriate, but is not enough for diffusion. And now that we're hearing about open access, there is a barrier in open access. We are assuming that most of the audience that will have access will be proficient in reading in English. And that is a very dangerous assumption. Translating is expensive, but it's necessary and probably should be part of our planning when we're trying to diffuse, that we are transmitting the messages both in the language that people speak and second, in lay language that is easy to understand but accurate. Again, thank you very much, Dr. Javier. Thanks a lot for sharing with us your wisdom.